Welcome to our session on SeniorFlix with Anne. We've been chatting about palliative care, what it actually means, and I'm getting a really good understanding of what that is. And I want to thank you for helping us to understand. I know this is what you do.
Okay.
And I would also say we're fortunate to have you here. I know you, Anne, as someone who really cares about the resident. And that comes through. It comes through when I'm talking to my chaplains and the pastors, and Anne's involved and wants the best for the resident. And it's not an easy job.
Right.
And I'm going to ask you a question apart from palliative care here.
Sure.
When did you start at Shepherd Village?
I started about 3 years ago. Yeah.
Okay.
So,
Right about the middle of COVID, was
yes,
it?
yes. That was fun.
Wow. Yeah, that was really a challenge. And and it was really difficult on the floors at that time as well. And not when a lot of other people were isolated, we were coming into work, and you were coming in on a regular basis and giving care. And what are some of the misconceptions? I'd like us just to chat about that, about the end of life. Family members at that point were really struggling too, because they weren't able to be here in the same way in which they normally would have been in the past. Is that fair to say? And so understanding what their loved one was going through was difficult then, but it still is now. When it comes to the end of life, it's definitely not something that we look forward to for a loved one. It's difficult. I think of my loved ones, and I've lost my father. He actually had what is called supranuclear progressive palsy, and yeah, anybody that knows what that is, you could just sort of put an acronym NASTY. It really was difficult to watch and go through with him. So when it comes to a person's end of life, there were things that we were asked, do you want this? Do you want that done? And we chatted a little bit about that in the last segment, but when it comes to their loved ones and end of life, what are some of the misconceptions that you deal with? And maybe we can help families understand as well.
Well, a lot of the times at end of life, individuals do start to lose their appetite.
Right.
Right. Now, this doesn't happen for everybody.
Yes.
But a lot of the times it does, especially in cases like, end stage dementia or things like cancer. They start to lose their appetite. For people with end stage dementia, they may lose their swallowing ability.
Okay.
And this distresses a lot of family members because they're concerned that their loved one, if they're not eating or they're not drinking or they're not rousable during end of life, they're suffering from hunger and thirst. When someone is at end of life, there are changes that happen in the body, right? The body is now conserving energy, and the way that it processes nutrients changes. So it can actually be more uncomfortable to sort of force someone to eat or drink or force like hydration in them when their body is unable to process those nutrients anymore, right? With these changes in the body and with conserving of the energy, the body actually has ways to suppress feelings of hunger. And then at the end of life, that natural dehydration helps to release like endorphins in the brain that help to sort of stop the individual from feeling those feelings of hunger or thirst or,
Right.
yeah,
So when we're talking about palliative, we're talking about an overall umbrella. In there, at some point, we will all come to a point of end of life.
Right.
And that is a more defined, I got the phone call about my dad.
Right,
and
right.
my sisters did.
Right.
Come and visit your dad.
Right.
Not because, he needs a visit. It's because it's coming to the end of his life.
Right.
How do you know that as a nurse?
So let's go back and, palliative care is an umbrella, right? It's a way of thinking. It's a paradigm.
Yeah.
It's a philosophy of care where you're
Right.
focusing on an individual's psychosocial, emotional, physical, spiritual needs, managing their symptoms, and trying to maximize their quality of life
Yes.
within the realm of their illness, right? Within that umbrella of palliative care, there's also the end-of-life care, which happens at the end when someone is imminently dying. So
Okay.
they're in like the final weeks or days or hours of their life.
Yes.
Again, someone can be palliative for years, right? Because again, they may have a terminal or a chronic illness or a life-limiting illness for years.
Yes.
And during that time, if they want palliative care, they're focusing on maximizing the quality of their life, right? And not undergoing all of these investigations or invasive treatments that may prolong or try to cure their disease, but may come with a bunch of other side effects or significant consequences that would affect their quality of life.
So when that's taking place, some of the family members are thinking, well, if we're withdrawing this kind of care in terms of the invasive stuff and CPR and so on, that we're actually causing them to die.
Right. So that's a huge misconception, because I want families to remember that their loved one has an illness or a diagnosis or a disease that is causing them to die, right? Or causing to have their natural death, right? And by stopping these treatments, you're not causing their death because they're already dying from their disease or their illness, right? So I think that's really important to remember. Sometimes I have families telling me, oh, I want you guys to do CPR and heroic measures and everything for the patient so that they can keep living until it's their time to have their natural death. But if you think about it,
that's not natural.
If an individual's heart has already stopped, that technically is a natural death. They have technically died. So if you're doing things like CPR or heroic measures to try to revive them, you're actually trying to bring them back from being dead, right? So you're actually trying to stop the natural death.
Yes.
And prolong their life a little bit longer.
Yeah. I've been with families in the emergency and trauma center and so on, where the person has come to the end of their life.
Right.
And there have been extraordinary measures that have been done, and the physician and the family are looking at it and coming to an understanding. None of those extra measures are going to make a good death.
Right.
And in fact, you may not even, you may just have somebody who is breathing, heartbeat, but that's it.
Right.
And that's not.
So it's really something to consider, like, really, what is the goal of prolonging life without quality of life?
Right.
Right?
Yes.
So really, in that case, you're focusing on quantity of life, but not quality of life.
Okay.
Right?
And who can best answer that question?
Right, so it's the individual, right? It's their life, it's their body. It's really important for them to have those discussions with family and determine what is a good death to them, right? So a lot of the times these days, with modern medicine, it's great in that, it can help. We can help treat a lot of diseases or treat a lot of illnesses, and then we can prolong someone's life, which is great if you're keeping or maintaining or improving the quality of life, right? But if you're doing all of these invasive interventions, all of these aggressive treatment, and there's no quality of life, you're really kind of prolonging the suffering.
And you're doing it mostly for yourself.
Right.
A lot of times it's selfish reasons, and I get that.
Right.
It's hard to let go.
Yes,
correct?
yes. I mean, honestly, families are so well-meaning. They want what's best for their loved ones.
Yes.
It's just a little bit misguided that sometimes they think that, oh, living a very, very long time
Right.
is the best thing.
Yes.
But it may not be, right?
We have in the healthcare industry, there's a lot of acronyms, and I guess in today as a pastor, one of the things that I was mandated to do when I communicate is make sure people understand. And so if you're talking about something people don't understand, then you're not really communicating to them. And when I hear the term POA, some people may not know, well, what's POA? Is it a plan of action? Is it person on alert? And we know that's not the case.
Right. So in healthcare, a POA refers to a power of attorney. And you have, a power of attorney of care, power of attorney of finances. It's really important for people to know that as a power of attorney, you're being appointed by if you're appointed by someone to be a power of attorney,
Yes.
your role is to help act on their behalf and carry out their wishes.
Yes.
In the event that they are unable to express their wishes or express their wants on their own, right?
Okay.
So it's important to keep in mind that, if an individual says, they don't want CPR, they don't want life-prolonging interventions, you as a POA, it is your job to follow their wish.
Can we come back to this?
Of course.
We've come to the end of our segment at this point, and I think what you're talking about right now is really important. And maybe we could just come back to this, Anne, and just finish up our segment with discussion about power of attorney. Okay? Thank you.